Thank you very much, Dr. Walid and Dr. Ashraf, for inviting me to this conference. My talk today about a bit of missed pitfall in critical care echocardiography. I have no disclosure. When we talk about the left ventricular outflow obstruction, what hits mind for the first thought is the hypertrophic cardiomyopathy. It have been described since the 60s, and it is well known. It is a dynamic obstruction, and traditionally described with a systolic anterior motion of the mitral valve, and there are many mechanisms underlying the systolic anterior motion, or SAM, narrowed LVOT the distance, apically positioned papillary muscles, which tether and pull the mitral valve plane towards the ventricular septum, making the outflow more narrowed, and elongation of the anterior mitral leaflet, which make it more susceptible to move anteriorly. And lastly, but not least, the Venturi effect, when we have a high velocity jet across the LVOT during systole, this drags the mitral valve towards the ventricular septum. So the LVOT obstruction in hypertrophic cardiomyopathy, it is a dynamic process, and it is influenced by factors which alter the left ventricular contractility and loading, either preload or post-load. So if we have this echo of tri-chamber view, and we can see there is significant thickening of the septum, and the anterior mitral valve leaflet moving towards the septum. And whenever we talk about SAM, we need to have a timing. So we have a timing either by flow. So we have the characteristic flow, which is saber or dagger shaped. And in particular, it will show the late systolic high velocity in continuous wave Doppler, or we can use the M-mode. M-mode we utilize with the parasternal long axis view, and we put the cursor over the mitral valve leaflet. Then normally, whenever we have no SAM, we have the normal movement of E and A of the anterior mitral valve leaflet in the stall. And in systole, we have a good distance between the septum and the mitral valve when there is a coaptation of both mitral valve leaflets. However, when we have SAM, we don't have this distance between the septum and the mitral valve coaptate leaflets during the systole. So we have here systolic anterior motion of the mitral valve touching the septum in systole. All right. The hypertrophic cardiomyopathy, SAM, as we said, it is very characteristic to hypertrophic cardiomyopathy. But does it occur in other symptoms? Yes, there are many conditions where SAM shown to be not exclusive to hypertrophic cardiomyopathy. It is known and well described in hypertensive heart disease, patients who have poorly controlled diabetes with stiff left ventricular and greater left ventricular mass. In acute MI, particularly if you have LAD territory, SOL territory, with compensatory hyperkinesis of non-infarcted segment at the base, or it is well described in many cases of stress dobutamine echo, particularly in elderly female patient with a small left ventricular cavity. Also, after mitral valve surgery with redundant tissue on the posterior mitral valve leaflet, and after general anesthesia, particularly in hypovolemic patient. So this is the cartoon which shows we have the posterior mitral valve leaflet, we have anterior mitral valve leaflet, and this is in the 5-8 chamber. So we have the systolic anterior motion to occlude the LVOT during systole. So we have here the obstruction. This patient does not have hypertrophic cardiomyopathy, but he had significant a bit of hypertrophy of left ventricle, and we can see there is obstruction of the LVOT. Again, if we utilize the Doppler, we will see the characteristic late systolic saber or the dagger-shaped accentuation of the flow. So if we come to LVOT in critically ill patients, we have two main issues we need to be careful about it. We have a precipitating factor and we have a predisposing anatomical substrate. So those predisposing factor, if there is certain anatomical substrate, we can have LVT obstruction. So if we talk about what those predisposing anatomical factors, if we have a significant left ventricular hypertrophy, patient long-standing hypertensive, patient have aortic stenosis with sigmoid septum, patient with regional wall motion abnormality after MI, apical ballooning with Takotsubo, misplaced mitral valve prosthesis. So we have over the last, yesterday and today, we hear from Professor Zafir and from Dr. Ashraf Tayar and Dr. Antoine about be careful with the fluid because it have a deleterious effect. This is one of the pitfalls. So if we have such patient with Takotsubo, with apical ballooning, this patient, if you just treat with excessive inotrope, you can end up with LVT obstruction. We have a patient with LAD territory dyskinesia. Again, this is a patient who is predisposed to have LVOT obstruction. If we have such hyperdynamic heart, this hyperdynamic heart is begging you to for fluids. And if you give inotrope to improve the hemodynamics of the patient, you may end up with the other way around, with deterioration of his hemodynamic. So the precipitating factor is the increased left ventricular contractility, excessive use of inotrope and chronotrope, in particularly with the dobutamine, and decrease preload or the afterload. Patient with hypovolemia, with hemorrhagic shock, with severe sepsis and vasoplegia, or post-operative cardiotomy. In short, those patients with small hypercontractile left ventricle, be careful in those patients that they may develop LVT obstruction. So we have many clinical situations in ICU where we face possibility of this. If you have a patient with decreased preload, with a small left ventricle, due to either hypovolemia, bleeding, surgery, post-operative, with anesthesia, patient tachycardic, either due to pain, arrhythmia, excessive use of inotrope, fever, septic shock patient, or anesthetic patient with valsoplegia, and lastly but not least, patient on mechanical ventilation who are hypovolemic. So this patient, they are very susceptible. So as we also we have, as we talked before, with MI, with compensatory hyperkinesis of preserved segment, particularly the basal parts. And if you have a post-mitral valve repair, particularly with the use of rigid ring and use of inotrope, and if there is a blood loss, or patient who had long-standing aortic stenosis with significant left ventricular hypertrophy, be careful after you have either replacement of this aortic valve or TAVI that they may have LVOT obstruction post surgery. Also, lastly but not least, patient with acute or chronic cor pulmonale. When you have a small left ventricle and the mitral valve moves near to the septum, and there is a change in the left ventricular geometry. So we have a lot of case report have about dynamic LVOT obstruction in critical ill patient. And we have our colleagues in France, Chauvet et al. They reported significant up to 22% in septic patient. This was a single center study with, it is a prospective study carried over 28 days. So they recruited 962 ICU patients over the period of study of 28 months. Out of those, they excluded patients without septic shock, and they included 218 patients with septic shock. Nearly 1/4 of those patients, 47 patients, they found that they had septic shock with intraventricular obstruction, and the rest of the patient did have only septic shock. Does this have consequences in those patients? Yeah, you find those patient mortality, patient with intraventricular obstruction, nearly double those patients without intraventricular obstruction. And their mortality not only in ICU, the mortality up to 1 month post admission, it was higher in those patients. Keep in mind, they were matched for all the other demographic characteristic. So this was a really serious finding. Not only this, they found that the intraventricular obstruction have much improved after volume expansion. So the flow have changed from this characteristic dagger shaped with late systolic accentuation to the normal symmetrical shape after fluid replacement. And the gradient over the LVOT much reduced after fluid resuscitation. So we have to be very careful because we have now change of paradigm from liberal fluid to more conservative fluid, particularly in those patients who had ARDS, who are mechanically ventilated. So we need just to keep in mind about this. And the intraventricular obstruction can happen in multiple levels. It can happen in the mid ventricle, or it can happen in the LVOT. So you have to have this sort of clinical suspicious. If you have a patient who is not really responding to inotropic support, it may incorrectly attribute it to worsening sepsis or having heart failure or septic cardiomyopathy. It is very simple maneuver. You need to detect. Just if you think about it, you will easily find it. So you can detect the LVOT obstruction by simple Doppler, or sometimes the 5-chamber or 3-chamber is difficult to get in ventilated patient. Go to parasternal lung axis view and utilize the M mode, and you will find if there is anterior motion of the mitral valve. And this is really very simple trick. You just need to think about it. If you have a small hypercontractile left ventricle, as Dr. Ashraf mentioned, it is very important to have on those septic shock patients, you have a preliminary echocardiography. And later on, you can repeat it and see what's happening with this patient. So if you have such LVOT obstruction, you can simply reduce it by appropriate fluid loading. You increase the afterloads using norepinephrine, and you treat the underlying. So avoid positive inotrope, particularly the dobutamine, control arrhythmia, and beta blocker have a genuine role to play on those patients, because whenever you slow down the heart, you will reduce this dynamic obstruction of the left ventricle. And this allows more time for filling of the left ventricle. This is small ventricle needs more time to fill up. And whenever you give it more time, you reduce the dynamic obstruction, you end up with, by the end, increasing the cardiac index and cardiac output. So we have this patient, he came to us with MI, and he was not amenable for angiography. The preliminary echo showed there is a significant septal thickening, and he had a mid-cavitary hypertrophic cardiomyopathy. His ejection fraction was fair, around just 30%. And intraoperative, our colleagues in cardiac anesthesia and the surgeon, they thought this patient is not amenable for surgical myomectomy or injection to reduce this, and they thought this is not really serious. However, because this patient had received ticagrelor preoperative, and his course was complicated with a lot of bleeding postoperative, so we end up that he had a bit of significant LVOTO obstruction. And this is the TEE, and we can see the turbulent flow at the LVOT. And patient was a bit, giving us a bit of hard time. And we ended up with stopping dobutamine, giving low dose esmolol, and patient survived and he did very well. So those patient management in short, the inotropes, beta agonists, diuresis, vasodilation by nitrates, it should be stopped or at least reduced. You have to give them fluid challenge, and it can improve both the preload and improve the left ventricular size. And you go to this part in Starling law whenever you have more stretch of the left ventricle, and you improve the cardiac output, particularly if you have no right ventricular dilatation, you have no issues with the right ventricle. Non-vasodilator beta blocker is a very good drug to treat such patient to the maximum tolerated doses. If you have a contraindication to beta blocker, diltiazem, verapamil, or diazepam are another alternatives. So my take-home message that LVOT is an underestimated dynamic phenomenon in ICU. So far, we have a lot of studies. We have more of case reports. We have Chauvet colleagues study about this patient in septic shock. Just you need to think about it. Whenever you have a preliminary echo of a septic patient with hyperdynamic heart, small left ventricle, think about if this patient is not improving with inotrope, think about he may need more fluids. If patient is tachycardic, if you have evidence of hypovolemia, if you look for his IVC and EC, it is collapsing. So this is a good way of picking those patients. And you can pick them very easily by echocardiography. Unfortunately, those patients, if you go blind without having echo, you end up, this patient, you give higher doses of inotropes, they go more tachycardic and they deteriorate more and more and more. So if you have hypotension, low cardiac output, not responding to typical treatment, and even worsening with positive inotrope or vasodilator agent, think about LVOT obstruction. It's very simple. Get an echo, have either Doppler flow or M-mode, and you will see very clear SAM in those patients. And you treat, as we mentioned, try to stop inotrope or reduce it, give more fluid, and the beta blocker can be considered in those patients. And thank you very much. Those are my references, and many thanks to all of you.
Fantastic. Thanks very much, Dr. Walid. I think we are just about the time now. We can take one question here. Dr. Walid, Dr. Hisham, what do you think about LVOT obstruction in HOCM in the M mode compared to the 2D mode? Will it be easier to assess? And the second question would be by Dr. Walid Shebl after me.
The M mode probably is the easiest to detect the sound, especially in ventilated patient. Barsternal view, long axis is probably the most easy window we can get. Sometimes trying to get a 5-chamber or 3-chamber view sometimes is difficult. Although dagger-shaped or saber-shaped Doppler is really characteristic to sound.
Dr. Walid, do you have a question?
Yeah, I know you saw a lot of patients in Batten Cardiac Center. There is incidence of HOCM in septic patient. They mentioned it reached to 25% of septic patient has an element of HOCM. What about your experience, Dr. Hisham, in big center, big Batten Cardiac Center? How you find this number?
Probably we didn't have such figure. We don't see a lot. Maybe this patient, we thought about it because we know from the very start that this patient had a bit of septum thickening, and he was unlucky because he had ticagrelor preoperative and he had a lot of bleeding post-operative. So we thought about it and we documented and we treated with beta blocker and we stopped norepinephrine and dobutamine, but we didn't really find it that common. As I said, it is an area which need really, you can have more research on this area. Particularly, I think whenever you have patient, you think, oh, this is elderly patient. He had a stiff heart, coming with septic shock, and he's not improving. Just give it a thought. Hello?
Okay, perfect. So I think we will conclude here the third session.